Today's webinar is about treatment options that are available for lymphoma patients following CAR T therapy. We chose today's topic because it's important for patients to understand the treatment options they have available at all stages of their cancer journey. We are very excited to have Dr. Melody share her expertise on this topic with us today. Dr. Megan Melody is a hematologist-oncologist at Tampa General Hospital Cancer Institute and an assistant professor at University of South Florida College of Medicine. Dr. Melody specializes in lymphoma and cellular therapies, and her research focuses on stem cell transplant, CAR T cell therapy, and bispecific antibodies. She is passionate about improving patient outcomes and reducing treatment-related toxicities. And with that, I will turn it over to Dr. Melody for her presentation.
Thanks so much, Hannah. Just let me know if I need to reshare my screen.
Yes, please reshare your screen.
Is that showing up for everyone?
Yep, that's perfect.
Wonderful. Thanks so much for the introduction. As Hannah mentioned, my name is Megan Melody, and I work at Tampa General Hospital, this beautiful hospital pictured in the left-hand side of your screen. And today we're going to be talking about treatment options for lymphoma following CAR T cell therapy relapse. Oh, you know what? With the new screen share, my slides are not advancing, Hannah. Let me try again. Give us one moment.
I I think if you double click on your slides, you may be able to advance it.
Yes, thank you very much, Marisol. All right, we're how many years into virtual meetings and still some technical difficulties. So these are my disclosures. And so here are our objectives for our talk today. I could spend probably whole talk in and of itself talking about lymphoma, different subtypes of lymphoma, diffuse large B-cell lymphoma in particular, which is where the focus of our talk will primarily be today, in particular CAR T cell therapy, including patient selection and toxicities. But my hope is that as you come to this talk, that you have a fairly solidified foundation in those topics, and we'll touch briefly on them throughout the topic. But this topic really is to give a brief overview on CAR T cell therapy, but then really to focus on subsequent treatment options after CAR T cell failure. So once someone has had a relapse or progression of disease following receiving their CAR T cells, and then really each therapy that we go over, we'll talk about the efficacy of those therapies, how those therapies are dosed and administered to patients, and then most importantly, patient-specific variables that impact the selection of these treatments. So before we get going, like I mentioned, having an understanding of the type of lymphoma you have, the prior lines of treatment that you've had, and what CAR T cell therapy is would be beneficial. But we can kind of work if you're coming to this talk without that. So I just want to lay down some words that sometimes us as oncologists tend to throw out to patients in a meeting during a clinic visit, where it's really helpful to provide some clarification on what those mean. So I'll be using some of these terms quite frequently. So a line of therapy is actually, we give each type of therapy that a patient receives a number. So it doesn't matter what the therapy is, but if you are receiving the very first treatment you've had for your cancer, we call that first line treatment. And then subsequent therapies are given a sequential number. So for example, if someone receives a first treatment for their cancer and then goes on to receive a second treatment, we call that second line therapy. So think of it like a tool in your toolbox. There is a difference between these words relapse and refractory, which is what we often use when we use these often interchangeably, but there is a difference. So a relapse cancer is a cancer that recurs after a period of remission or a significant improvement in disease. Whereas refractory means that the cancer never really responded to treatment or only had a mild response and then progressed. A complete response means that when we look at these images on our computer or on our screen, we are not seeing any evidence of cancer. And now, even on a molecular level, some of these hematologic cancers, we are actually even able to detect them on a DNA level in your blood. So now some cancers, we're utilizing a molecular complete response, meaning that we can't even detect those molecularly. Essentially, it means we can't detect the cancer. Whereas overall response rate just means people who are responding to treatment, so whose cancer is getting smaller or shrinking. And so that's a combination of patients who are partial responders and complete response. So the overall response rate should always be higher than the complete response rate because the overall response rate includes patients who have a complete response. And lastly, duration of response. We use this a lot. Sometimes it can be very similar to a term that your oncologist may use, like progression-free survival. But really, this is how long those patients who get a response hold that response. And that's really important because I can tell you that your cancer may disappear with this treatment, but if it's only gone for a day, that doesn't really matter. So the duration of response is quite important when we're discussing these therapies. So now that we've discussed those words, let's talk a little bit briefly, just before we get into the therapies after CAR T-cell therapy, what CAR T-cell therapy is. So essentially what CAR T-cell therapy is harnessing the power of your immune system to fight your cancer. And we do this in a lot of ways now in cancer with PD-L1 inhibitors, bispecific antibodies, which we'll talk about later in this talk. But really what this is harnessing your T-cell immunity. And so the cancers that we're going to talk about today, lymphomas, particularly B-cell lymphomas, are a cancer of your immune system. And so what this therapy does is essentially takes the T cells out of a patient's body, sends them to the lab and trains them to fight cancer. And then we give a patient a little bit of chemotherapy, just sort of to make room for those T cells. The chemotherapy isn't really to treat the cancer itself, but really to make an immunologic space for these T cells we're about to give back to the patient. And then we give them back these genetically modified T cells, and those T cells are able to recognize and fight the cancer. So just a little bit more specific about how this process occurs. A patient's T cells are collected through a filtration process called leukapheresis. The T cells then are sent to a lab, depending on the manufacturer of the CAR T cell. These can either be industry manufactured CAR T cells, or occasionally on clinical trials, they can be locally manufactured at a medical institution. So these T cells undergo selection and genetic alteration in the lab through a process called viral transduction. And that results in an expression of a protein or a chimeric antigen receptor. So that's where we get that name CAR, because no one wants to say chimeric antigen receptor. And that's expressed on the surface of the T cell. CAR T cells are then expanded in the lab to obtain a sufficient number of cells. And then once the cells are ready, the patient receives lymphodepleting chemotherapy regimen. It's usually 3 days of a combination of cyclophosphamide and fludarabine to make that immunologic space. And typically this occurs while they're in the hospital, but occasionally larger cancer centers can do this outpatient. And then these modified T cells are infused into the patient. And that's considered day 1 of CAR T cell therapy. The patient is monitored closely for toxicities, including a syndrome called cytokine release syndrome, which we'll discuss briefly, and a neurotoxicity syndrome called ICANS. This typically occurs within the first week of CAR T cell therapy, but has been reported as late as 60 days out from CAR T cells. So patients are followed quite closely for the first 60 days. And while different products have different toxicity profiles, like I said, most symptoms present within the first week to 2 weeks. So there are 6 different CAR T cell constructs or products approved for the treatment of blood cancer and 4 approved for the treatment of lymphoma. These products vary by manufacturing technique and the actual construction of the CAR. They each have different indications based on the clinical trials that led to their approval, as well as different efficacy rates and treatment-related toxicities. There's a bug. 3 of these constructs are approved for the treatment of large B-cell lymphoma, which, as I mentioned, will be the primary focus of our talk today. Because although 70% of patients with diffuse large B-cell lymphoma are cured with frontline combination of chemo and immunotherapy, which again, as I mentioned, means the first type of treatment or chemotherapy or patient receives, about 30% of patients will have disease progression during therapy or relapse after frontline treatment. So we call that relapse or refractory. For those patients who relapse within 1 year of treatment, or have received a second-line treatment for diffuse large B-cell lymphoma, so a second attempt at getting a complete response, CAR T-cell therapy is a potential treatment option. And there are a variety of factors that go into determining whether CAR T will be safe and an effective treatment for a patient. And again, that could be a whole nother topic of a talk. So we're not going to get into this at that time, but that's really something I encourage you to speak to your oncologist about, because there are factors that make someone a good candidate or a bad candidate for CAR T cell therapy, just meaning that maybe this therapy wouldn't be safe in specific patients or beneficial. But for those who are selected to receive CAR T cell therapy, treatment is very effective. Clinical trials analyzing CAR T cells show that anywhere from 52 to 88% of patients will respond to therapy, depending on which construct is used, what disease is utilized for, and how many prior lines of therapy that patient has received. And anywhere from 40 to 75% of patients will have a complete response to therapy, with the average duration of response ranging anywhere from 11.1 months to greater than 2 years. As you'll see, there's a not reached or an NR in a lot of the columns of this table, and that just means that we, on the most recent data, we still don't have 50% of patients relapsing. So that's what median duration of response means. It means how long did it take till 50% of patients had lost their response? And at extensive follow-up data for some of these clinical trials, greater than 3 years, those patients still are not relapsing. However, despite their marked efficacy, studies have shown that 40 to 60% of patients will experience CAR T cell failure. And so in this talk, we'll discuss potential treatment options for patients with relapsed or refractory disease after CAR T cell therapy, which we'll sometimes refer to as CAR T failure. So the first thing we're going to talk about is bispecific antibodies. And this in particular is a passion of mine in terms of sequencing bispecific antibodies in CAR T cell therapy and really trying to figure out optimization of therapy. So truthfully, if I really get going, I could spend the entire hour on this topic. So bear with me that I'm going to glaze over some things because we do have 3 bispecific antibodies approved in this space. And so each one could be a whole talk on its own. So first, what is a bispecific antibody? So if you remember when I was just talking about CAR T cell, I talked about harnessing the power of a T cell to fight a lymphoma. And so, like I mentioned with CAR T cell therapy, we actually take a patient's T cells out of their body, train them to fight cancer in a lab, and then infuse them back into the patient. But that takes time. So CAR T cell manufacturing can take anywhere from 2 weeks, that's the shortest I've heard, but up to 5 weeks. And sometimes patients can't wait for that, or patients often can, like I mentioned, 40 to 60% of patients can relapse after CAR T cell therapy. And so a bispecific antibody is another method to sort of harness the same power in the body without really removing a T cell from a patient. So what this is it's a drug that we give off the shelf, and we'll talk about how that's administered. But essentially, it has 2 arms on it, one that binds to a protein on the surface of the T cell, and one that binds to a protein on the surface of the cancer cell, and essentially brings the T cell and a cancer cell close together in proximity to allow the T cell then to cause cancer cell death by T cell mediated apoptosis, which means cancer cell death or cell death. So there are 3 types of bispecific antibodies approved for the treatment of lymphoma. And so we're going to kind of talk briefly about each one of these, but glofitamab is used to treat large B-cell lymphoma. It's administered intravenously. Epcoritamab, or Epkinly, is treated as indicated for large B-cell lymphoma and follicular lymphoma and given sub-Q. And then mosunetuzumab, I know I said I was going to focus on diffuse large B-cell lymphoma, but I have to mention it here because we're going to talk about it in combination with another agent later. But in terms of single agent therapy, it is not approved by the FDA yet for any treatment outside of follicular lymphoma, and that's given intravenously. So let's delve into a little bit about what that means for how it's given. So glofitamab is actually dosed every 21 days. I say that, but if you look at the very first half of this slide, it's cycle 1, you'll see that there's multiple days within cycle 1. So glofitamab is typically given every 21 days, and it's given for a set period of time for 12 cycles. But during the first cycle, you're actually coming in every week. So you're coming in on day 1, day 8, day 15 of cycle 1, and day 1 of cycle 2 before you move to that 3-week regimen. So really the first 4 weeks is a heavy lift for a patient because they're coming in every day, once a week. Additionally, for the second dose, so the second week, the very first dose of glofitamab, day 8, we do recommend being hospitalized at most institutions. Some institutions have transitioned to doing this outpatient, but the majority of institutions are still doing this inpatient for 24-hour monitoring after the dose. This is to monitor for treatment-related toxicities, which we'll talk about in a minute. If a patient does develop those treatment-related toxicities, it is recommended that patients also be admitted for their subsequent dose on day 15. So additionally, if patients are developing toxicities with their day 8 dosing, it typically is not just a 24-hour hospitalization. And I want to mention that because, being hospitalized for someone who has just received CAR T cell therapy at some point in the past, already spent quite some time in the hospital, another hospitalization can sometimes seem daunting. I also just want to draw your attention, something unique about the glofitamab dosing is you'll notice that you actually don't get your first dose of glofitamab until day 8. Day 1 dosing, so the very first day of the very first cycle, you're getting a drug called obinutuzumab, which is quite similar to a drug called rituximab, which I'm sure a lot of you have received with your first-line chemoimmunotherapy. But this is essentially to reduce the number of malignant B cells in your body in an attempt to mitigate those side effects that we'll talk about with associated with glofitamab therapy. Epcoritamab is a similar bispecific antibody to glofitamab. This drug is given subcutaneously, and it's given on a very different dosing schedule. So this drug, technically the dosing is every 4 weeks, but you'll notice up till cycle 9, you're getting these treatments much more frequently than once per cycle. So for the first through third cycle, patients are coming in weekly. However, this treatment is administered subcutaneously, meaning as an injection, so not an IV infusion. Both glofitamab and epcoritamab do not need to be given via a port. So for those patients who've had their port removed after their frontline chemotherapy and never got another one for CAR T, you are not necessitated to get a port for this treatment either, which is a benefit. Epcoritamab, like I said, is also given subcutaneously, so it's a little bit of a shorter visit than glofitamab. But you'll notice that you don't have the obinutuzumab pre-dosing. Additionally, for this treatment, on cycle 1, day 15, so still that second dose, that third dose, sorry, the purple dot under week 3, it is recommended that patients be hospitalized for 24 hours after the administration for monitoring of CRS and ICANS. And again, the treatment-related toxicities I'll mention in a minute. But again, these are ever-evolving situations. And as academic centers get more comfortable with administering these medications, most of these will most likely be transitioned to the outpatient setting within the next few years. And then lastly, mosunetuzumab. Mosunetuzumab is an entirely outpatient administered bispecific antibody. It also has a step-up dosing, and its dosing is every 3 weeks. It is given intravenously, just like glofitamab, and it is also given for a standard subset of time. So if you are able to achieve a complete response, meaning your disease is gone on imaging, the recommended dosing is for 8 cycles. However, if someone is just able to achieve a response, but there's still evidence of disease on their scan, then they can receive up to 17 cycles. I do just want to backtrack for a minute. That is the difference between glofitamab, epcoritamab. Epcoritamab, again, doesn't have that finite therapy like glofitamab does, which is 12 cycles for glofitamab. Epcoritamab, we are able to continue that therapy indefinitely. This can be considered a pro or a con, depending on how you look at it. It is nice to know that with glofitamab, you're only committing yourself to 12 months of therapy. However, if patients are continuing to respond to therapy, there is some questions on what to do if patients have a complete response to therapy, whether there's a potential to lose that complete response if they stop therapy. And so with epcoritamab, that is a discussion you're able to have with your provider. You can obviously always stop it if you don't want to continue the treatment, but there is the potential to continue the treatment should you be continuing to respond and tolerating treatment well. So again, these are pros and cons. It really depends on what your preference is, but these are discussions to have with your provider regarding sort of your goals and what you feel is best for you. So this talk is about efficacy of treatments post-CAR T-cell therapy. And so although the pivotal trials examining both epcoritamab and glofitamab only included about 1/3 of patients previously treated with CAR T-cell therapy, they demonstrated a complete response rate of about 30%, 35% with the use of bispecific antibodies in the post-CAR T-cell setting. However, that was a pretty small patient population. And so a group of institutions, a large multi-institutional study of real-world application of bispecific antibodies post-CAR T-cell therapy, examined 830 patients previously treated with CAR T-cell therapy, 429, which goes along with that number of 40 to 60% relapsing post-CAR T, did experience CAR T failure. And then 64 of these patients went on to subsequently treated with bispecific antibodies. And the overall response rate that was reported out to this subsequent use of bispecific antibodies in this analysis, post-CAR T-cell therapy, showed a 54% overall response rate, meaning a combination of partial and complete response, with a complete response rate similar to the pivotal trials of about 33%. At a follow-up of nearly 5 months, 66.7% of patients with a complete response to therapy continued to have a complete response to therapy. So again, that median duration of response was not met at the last follow-up. More recently, bispecific antibodies in combination with chemotherapy have also been added to the NCCN guidelines, which is a set of guidelines set by experts in the field. For the treatment of B-cell lymphoma, there's an NCCN guideline, but for any cancer, there's an NCCN guideline set by experts in the field. And this is typically what your insurance uses to figure out whether or not they're going to pay for your treatment, or whether, and what doctors often refer to make sure that they're practicing most evidence-based and updated care. And so combinations of bispecific antibodies with chemotherapy have just been added to the NCCN guidelines as a potential treatment option for those patients ineligible for CAR T-cell therapy or autologous stem cell transplant, which is sometimes used for patients who relapse after frontline therapy. But it's also something to consider in patients who are extremely fit after CAR T-cell therapy, who maybe still had some chemo responsiveness. So for patients who just received frontline chemotherapy and, then went on to CAR T-cell therapy, it is reasonable to consider a combination of bispecific antibodies with chemotherapy. And so we're just going to touch on those briefly here, but really mostly they're included in the NCCN guidelines as an alternative to transplant or CAR T-cell therapy in those patients deemed ineligible. Okay, so glofitamab and epcoritamab were examined in combination with a chemotherapy regimen called GEMOX, and mosunetuzumab was studied in combination with polatuzumab vedotin, which is an antibody drug conjugate. We'll talk a bit more about what that is in depth later. And it's directed at a protein expressed on a cell surface called CD79B. Trials examining these combinations included a range of patients previously treated with CAR T-cell therapy, as seen in the second column, ranging from 7 to 35%, and in all patients, so not just patients previously treated with CAR T-cell therapy, demonstrated an overall response rate of 59.2% to 85%, and a complete response rate of 45.9% to 61%. So like I mentioned, the NCCN guidelines suggest these regimens for patients who are not intended to proceed with transplant or CAR T, but I think it's in a select fit group of patients whose disease previously responded to chemotherapy, these combination regimens could be considered. It's important to note that although these therapies are given in combination with a chemotherapy agent or an antibody drug conjugate, the actual dose ramp up for these drugs, both glofitamab, epcoritamab, and mosunetuzumab, hold as to what I was saying before. So both for glofitamab and epcoritamab, there is still that recommended hospitalization, and that does not exist for mosunetuzumab. Okay, so I mentioned some side effect profiles over and over and over again. So just like CAR T-cell therapy, these therapies include the T-cell engagement with your cancer. And so I mentioned briefly this cytokine release syndrome, which is a release of inflammatory interleukins and cytokines that mediate sort of a diffuse inflammatory response. So very similar to a flu-like syndrome, but can become quite severe. So these are typically characterized by hypotension, hypoxia, fevers, and then sometimes occasionally those inflammatory cytokines can cross the blood-brain barrier and enter the fluid that surrounds your spinal cord and brain and cause confusion, tremors, and in severe cases, sometimes seizure. And this is called an immune effector cell-associated neurotoxicity, or ICANS. These for most people who are joining this call, they're familiar with CAR T-cell therapy. And so these side effect profiles are much more common with CAR T-cell therapy and typically much more high grade, which is something we used to call a term severe. So these side effect profiles are seen more often with CAR T-cell therapy and are often more severe with CAR T-cell therapy, but can be seen with bispecific antibodies. They're typically short-lived. They normally occur within the first few days of infusing a bispecific antibody, and we do have pretty effective treatments for managing these symptoms. So ultimately, it is a side effect that can occur, but it is a manageable side effect and is much less common than the side effects you're counseled on for CAR T-cell therapy. All of these therapies that we're about to discuss today, every single one, you're going to hear me say the word cytopenias. Typically, that does always mean a low blood cell count. And most often when we're talking about cytopenias, we're talking about a low white blood cell count and a specific type of white blood cell called a neutrophil. We call that neutropenia. A low red blood cell count or hemoglobin, which we call anemia, and a low platelet count, which are those cells that stop you from bleeding if you get a cut or a bruise, and we call that thrombocytopenia. Obviously, if these cells are low, they're not able to do their job properly, and so it predisposes you to bleeding if your platelets are low, infection if your neutrophils are low, and fatigue and shortness of breath if your hemoglobin is low. Bispecific antibodies also, like I said, engage with your B cells. Your B cells are what make your immunoglobulins or those antibodies. And so typically patients who are treated with bispecific antibodies develop something called hypogammaglobulinemia, meaning that their drug is working effectively, their T cells are attacking their B cells, and so they don't have these B cells to make these immunoglobulins. That also means that if patients are getting a viral or a bacterial infection, they're unable to appropriately mount immune response. And so essentially what is recommended is that physicians monitor serum immunoglobulin levels and replace with something called intravenous immunoglobulins to replace the low immunoglobulin level in patients to help them fight these infections. Like I said, neutropenia is a side effect as well as hypogammaglobulinemia. And so infections are a common side effect with bispecific antibodies as they are with CAR T cell therapy. And then in particular with epcoritamab, because it is a subcutaneously delivered bispecific antibody, we can see injection site reactions. So what are some factors to consider when choosing bispecific antibodies? So as I mentioned, first and foremost, bispecific antibodies do have that unique side effect profile of CRS and ICANS. They also require an inpatient hospitalization for dose ramp up for epcoritamab and glofitamab. And so most places that are administering these treatments have physicians who are trained to monitor and manage symptoms of CRS and ICANS. So typically these are only being right now administered in academic settings with physicians who are comfortable managing CRS and ICANS associated with CAR T cell therapy. However, we are working very closely, at least at Tampa General, and I know at institutions across the world, to facilitate the dose ramp up portion for those first few cycles where patients are most at high risk for developing CRS and ICANS, and then transitioning them to their local oncologist, a local infusion center, where they can get treatment close to home to receive subsequent cycles, because the chances of CRS and ICANS developing at that time are less than 1%. So that's something that's in the process, and I know that we already have centers and a local oncologist administering bispecific antibodies in the community, and we're very excited about this. But that is something to consider when selecting these therapies. If someone is not near a site that can do this dose ramp up, this is not a potential treatment option for them. Again, these treatments are often Hi, if everyone just wants to include their questions in the chat, I'll be happy to answer them at the end of the talk. So these patients also require, like I said, for epcoritamab and glofitamab, a brief hospitalization, and for patients who just received CAR T cell therapy and probably underwent a quite prolonged hospitalization, that can be sometimes a big lift for patients. The bispecific antibodies engage with the CD20 marker on the cell surface. And so although there are plenty of studies that demonstrate, or some studies that demonstrate the efficacy of bispecific antibodies in B-cell lymphomas that have lost CD20 expression, meaning that we've used a drug that targets CD20 and the cancer has evolved to no longer express that protein on its cell surface. These bispecific antibodies still do work on those cancers, but the thought is that we have a lot of other lines of therapy that we're about to go through. So perhaps in those patients where if the CD20 is lost on these patients, we might be reaching for another therapy before we reach for bispecific antibodies. Patients who had recurrent viral or bacterial infections with CAR T cell therapy, or are having recurrent viral and bacterial infections post-CAR T, or while they're on bispecific antibodies, perhaps another treatment option is something to consider. Although most of the treatment options we'll go over today do include side effect of neutropenia, bispecific antibodies are really the only one we're going to touch on that causes hypogammaglobulinemia, so kind of that double hit in terms of really predisposing patients to infection. And then patients who had really severe CRS and ICANS who are presenting after CAR T cell therapy with CAR T failure and still have a significant burden of disease, I'm a bit more hesitant to proceed with bispecific antibody in those patients, or if I am proceeding with bispecific antibody, I'm typically administering those inpatient. All right, so the next drug we're going to talk about is something called loncastuximab tesirine, but I promise I won't make you ever say that if you come to see me, nor will your physicians. So loncastuximab tesirine, or Zynlonta, or as we call it, Lonca, is an antibody drug conjugate that binds to a protein on your cancer cell surface. It's called CD19, and then loncastuximab is subsequently internalized into that cancer cell. It then releases a specific chemotherapy inside the cell named PBD, which cross-links or affects the cancer cell's DNA, effectively keeping the DNA from replicating, and eventually the cell undergoes apoptosis or dies. Loncastuximab is very simply administered. It's given as a single IV infusion once every 3 weeks, and the infusion time is approximately 30 minutes. So very quick, is short visits for patients every 3 weeks. It's not requiring that weekly dose ramp up. But I do want to clarify that loncastuximab is also administered with some pre-medication. So we do give some dexamethasone orally before and after the infusion. So it's not simply just the 30-minute infusion, but it's very limited time in hospital. The landmark phase 2 study that examined loncastuximab for the management of relapsed refractory large B-cell lymphoma after 3 or more prior lines of therapy, this was called the LOTUS-2 clinical trial, showed a 48.3% of patients had an overall response rate and 24% of patients had a complete response rate. However, only 9.7% of patients included in this trial were previously treated with CAR T-cell therapy. So a larger retrospective study, this is kind of where you're going to see a theme of this in the talk, that once these therapies are approved, people then do larger real-world studies to examine their application in the post-CAR T-cell setting. So this larger real-world analysis examined 118 patients treated with loncastuximab after CAR T failure and demonstrated an overall response rate of 73% and a CR rate of 34% in patients previously treated with CAR T-cell therapy treated with loncastuximab, with a duration of response at 12 months. And the duration of response at 12 months was about 68% of patients. So you're never supposed to compare trials across the board because every trial recruits different patients with slightly different disease characteristics. But just to kind of give you an idea, this is patients treated with loncastuximab post-CAR T-cell therapy, very similar overall and complete response rates as bispecific antibodies in this setting. And this does not target that CD20 marker on the cells, but targets at CD19, so similar target as the CAR T-cell therapy, actually binds to a different portion of the protein of CD19. So we call that an epitope. Okay. And that's important as we talk about another therapy down the line for diffuse large B-cell lymphoma. These binding, where these drugs bind, becomes very important to your physician because we don't want to continue to utilize the same protein on a cell surface because essentially your cancer gets really smart and learns to stop utilizing that protein, and then your drug is no longer effective. So we want to make sure we're varying the way we're attacking your cancer. And so loncastuximab, although it targets CD19, targets an entirely different epitope. And so it can be utilized post-CAR T-cell therapy with very similar response rates to those seen with bispecific antibodies. All right, so fatigue, rash, particularly one that occurs when you go out in the sun, and holding on to fluid in your arms or your legs, which we call edema, or holding on to fluid in your lungs, which can be considered pulmonary edema or pleural effusion, are the most common side effects with loncastuximab, but they're very mitigated if patients take dexamethasone for 3 days surrounding their loncastuximab infusion, and also if they avoid the sun and use sun shirts, sun hats, sunscreen. I'm in Florida, so it's very hard to encourage patients to avoid the sun, but I do have patients who are very effectively utilize sunscreens and those big fishing hats to kind of prevent these photosensitivity rashes. So factors to consider when considering loncastuximab. So things we want to consider is administration. So as mentioned, in comparison to bispecific antibodies, loncastuximab is given once every 3 weeks, similar to the bispecific antibodies, but not requiring that dose ramp up. It's a 30-minute infusion, does not require a hospitalization. And because it does not associate with these unique side effect profiles like CRS and ICANS, it can actually be given in the community without that ramp up. So for patients who are not nearby an academic center or a center that is comfortable with giving bispecific antibodies yet, loncastuximab can be given locally. I do think that it is important to consider the continued expression of that CD19 profile on your cancer cells. Although there are studies that show that loncastuximab is effective with the loss of CD19, and you'll see that as a common theme throughout this presentation as well, it's more effective if patients are still expressing that CD19. And so again, because we have multiple lines of therapy and multiple targets for these drugs in someone who's lost CD19, I would still consider loncastuximab, but perhaps reach for an agent that targets a protein still expressed on their cancer cell first. And then for those patients with a history of heart or lung disease, depending on the type of heart and lung disease, I may be more hesitant to reach for loncastuximab simply because of that side effect of holding on to fluid that is, mitigated some with the prophylactic dexamethasone, but is not completely gone. And so for patients who have heart failure or very severe COPD, I may be less likely to reach for loncastuximab over some of the other therapies we're going to talk about today. So next, we're going to talk about tafasitamab and lenalidomide. And yes, these names continue to get more and more complicated. So tafasitamab, also known as Monjuvi, and lenalidomide, also known as Revlimid. So tafasitamab is a monoclonal antibody that binds to CD19 antigen expressed on the surface of lymphoma cells. And now you're probably saying, wait, I just heard about CD19, and you're right, you did with loncastuximab. But this drug actually binds to the same epitope as CAR T cell therapy. So whereas loncastuximab bound to a different portion of the CD19 molecule, this one binds to the same portion as CAR T cell therapy. It mediates cell death by tagging the cell for destruction by your immune system. Lenalidomide is a cancer drug that helps fight cancer, but actually truly by a variety of mechanisms, including boosting the immune system, stopping bad cells from growing, and blocking signals that help cancer cells spread. So this treatment regimen is administered in combination. So the tafasitamab is administered IV in the outpatient setting. You'll see the dosing here on the chart. So it is the very first cycle requires some pretty frequent visits. But they get less and less as you get going through therapy. And after cycles 12, you get so this is administered in combination with Revlimid, which is an oral medication. It's given daily, and each cycle is 28 days. So for the first cycle, you're coming in 5 times. Cycles 2 and 3, you're coming in 4 times. So once weekly for that month, those 2 months. And then after that, it goes to a bi-weekly regimen moving forward. And after a year of this, a little less than a year, because there's, it's 28-day cycles, but a little less than a year, patients switch to just the Monjuvi monotherapy or the tafasitamab monotherapy. The first dose is administered slightly slower than the rest of the subsequent doses of tafasitamab. So it's administered IV over 2.5 hours. Again, this does not have to be given through a port. It can be administered via peripheral veins. And the remaining doses are administered faster. So those infusions typically last 1.5 to 2 hours. So still not a long time you're spending in the hospital, but we're in your infusion center. They don't require an inpatient hospitalization, but you do have to come in quite frequently for the first 3 cycles. Give me just 1 second. I need to just take a sip of my recording. Okay. So the L-MIND clinical trial, which examined the use of tafasitamab in patients with relapse refractory diffuse large B-cell lymphoma who were deemed not to be candidates for auto transplant, actually enrolled patients in 2016 and 2017. So that was really before CAR T-cell was commercially available, and therefore did not include patients previously treated with CAR T-cell therapy. But regardless, in patients who received an average of 2 prior lines of therapy, the combination of tafasitamab demonstrated an overall response rate of 60% with a complete response rate of 42.5%. A retrospective analysis, so again, that real-world retrospective analysis that we saw with bispecific antibodies, then with loncastuximab, now we're seeing it with tafasitamab, of patients treated with CAR T-cell therapy in France, examined 52 patients treated with tafasitamab after CAR T failure and demonstrated an overall response rate of 13.5% and a complete response rate of 7.7%. So that is significantly lower than the overall response rates and complete response rates we were seeing with bispecific antibodies and with loncastuximab. However, again, I do want to mention that in the scientific community, we do not recommend cross-trial comparisons, but we do have to make the treatment decisions for patients based on the data we have. And so you do wonder if perhaps some of this blunted response to therapy that is significantly different than the findings in the L-MIND study are because these drugs bind to the similar epitope to CAR T-cell therapy, and therefore the cancer cells that remain after CAR T-cell failure have learned to adapt to a CD19 targeted therapy. The data did show in this retrospective study that outcomes were better for patients who relapsed greater than 6 months after CAR T-cell therapy, which goes along with kind of what I was saying, that patients who relapse who have some response to CAR T-cell therapy may do better with tafasitamab. The most common side effects with the combination of tafasitamab included low blood counts, so that's cytopenias, neutropenia, anemia, and thrombocytopenia, fatigue, and diarrhea, but fatal strokes and infections were seen in 5% of patients treated with the combination of tafasitamab for relapse and refractory diffuse large B-cell lymphoma. So what factors do I consider when choosing tafasitamab? So again, this is a medication that does not require that specialization in managing CRS and ICANS. It does not require hospitalization for ramp up, so these can be given locally. I do consider that CD19 status. So in patients who lost CD19, I typically am not reaching for not reaching for tafasitamab in those patients, just given the blunted response already in the post-CAR T-cell setting. patients who did not have any response to CAR T cell therapy. So those patients who didn't have that 6-month response to CAR T cell therapy, I probably am not reaching for tafasitamab frequently. And patients with a significant stroke history or AFib, I'm also probably not reaching for tafasitamab in those patients, because those patients do have because of the high risk of stroke and fatal strokes that was seen in the clinical trial. All right, so now we're going to talk about a combination again with lenalidomide and rituximab, but we're adding brentuximab vedotin as well. So what is brentuximab vedotin? Brentuximab vedotin is a small antibody drug conjugate, or an ADC, that works by a similar mechanism to loncastuximab tesirine to target a protein called CD30 on the surface of a lymphoma cell. So we talked about CD79B, we've talked about CD20, CD19, now we're talking about CD30. BV is then subsequently internalized and then releases a specific chemotherapy inside the cell named MMAE, which disrupts the framework of the cellular components needed to utilize and grow and divide, and therefore leads to cancer cell death. This drug has been studied in a combination with lenalidomide or Revlimid that we just discussed, in combination with tafasitamab, and also rituximab, which is the monoclonal antibody that targets a protein on the surface of a lymphoma cell called CD20. This drug is often used as part of frontline treatment, but functions similar to tafasitamab to tag the lymphoma for destruction by your immune system. So these drugs were studied in combination as a triplet therapy. The trial was designed comparing it to R-squared alone, which is another treatment that can be utilized for the treatment of relapse and refractory large B-cell lymphoma. So this was a large phase 3 clinical trial. It compared 112 patients treated with BV R-squared with just R-squared for the treatment of relapse refractory diffuse large B-cell lymphoma after 2 prior lines of therapy. Patients were given brentuximab IV over 30 minutes, plus rituximab over 4 to 6 hours every 3 weeks. This was done in an outpatient setting. Again, this can be done peripherally, but most patients do have a port for these infusions. And then they took lenalidomide orally every day. Treatment was continued until progression of disease or treatment intolerance or discontinuation, so not that finite duration of therapy. So in this clinical trial, only 32 patients, or 29% of patients, were previously treated with CAR T cell therapy, but another 14 patients, or 13% of patients, previously were treated with that CD20 T cell engaging bispecific antibody. And overall response rates for the total patient population were 64%, with a complete response rate of 42%. In comparison to R-squared, which, like I mentioned, is another alternative treatment regimen that can still be used in patients unable to tolerate the combination regimen with BV, that had an overall response rate of 41.5% and a complete response rate of 18.6%. And then, as this regimen was just published and granted FDA approval earlier this year, we do not yet have that large real-world application data set of the use of this combination of therapy post-CAR T. So we have to rely on this subset population that was included in that clinical trial of 32 patients that did seem to have similar response rates to the overall patient population in this trial. The most common side effects were, again, low blood counts. So you'll see that, like I mentioned, with every treatment. Diarrhea in 31% of patients. Infections, most notably pneumonia, and then due to the timing of when this clinical trial enrolled, COVID. Peripheral neuropathy is a common side effect with BV. So 31% of patients develop peripheral neuropathy, and then 12% of patients experienced treatment-related death. So not a small portion of patients. So factors to consider when choosing BV R-squared is, again, this administration is not associated with CRS and ICANS, so does not require that specialist that's comfortable with managing those toxicities, does not require inpatient hospitalization, can be given locally. I do consider CD30 status on these cells. So again, I want to make sure that these cancer cells are still expressing that CD30 component, but I will mention that a subset analysis did show that this drug was efficacious in CD30 negative patients, but given the fact that I just outlined all of the other targets we have for treatment in a patient not expressing CD30 status, I would probably reach for another therapy first. But this drug is still efficacious. I think I was outlined on this previous slide. In these CD30 negative disease, we did still see a overall response rate of 60.5% and a CR rate of 40.8%. In patients who have a baseline peripheral neuropathy from their previous treatment, or maybe who are master crafters or guitar players, I may not utilize this treatment just due to the toxicity associated with BV. And then again, we do want to consider those prior lines of therapy that may be precipitating these side effects, like profound cytopenias or peripheral. other therapies. So here, before we get into a few other therapies, because I am getting towards the end of our talk, I do want to briefly mention that BTK inhibitors, so things like ibrutinib, acalabrutinib, zanubrutinib, can be utilized for patients with relapsing disease post-CAR T-cell therapy. Their efficacy as monotherapy in this setting has not really been evaluated extensively, but often can be added to treatment regimens to potentiate effects, and is now being studied in the post-CAR T-cell setting as a maintenance therapy or a therapy to help potentiate the effects of CAR T-cell therapy. Radiation therapy has been demonstrated to be a very good therapy post-CAR T-cell therapy in patients who have a very small amount of residual disease. And there is some thought that, again, this therapy does help to potentiate or expand CAR T-cells inside your body that are still present. And then there are a bunch of additional treatments, which we won't talk about during this talk, that are available for patients who have just relapse within their central nervous system, so within their spine and their brain, and that kind of falls outside of the scope of this talk, but there are an extensive amount of regimens available for patients with that specific type of relapse. So briefly, I just want to give a brief shout out to polatuzumab. We briefly mentioned polatuzumab when we were talking about the combination of Polin and that bispecific antibody mosunetuzumab. Polatuzumab is an antibody drug conjugate to CD79B on lymphoma cells. It can be used as monotherapy or in combination with rituximab or rituximab and chemotherapy agent called bendamustine. Polatuzumab vedotin with bendamustine and rituximab demonstrated an overall response rate of 41.5% and a CR rate of 38.7% in patients who had relapsed and refractory diffuse large B-cell lymphoma, but that is not specific to the evaluation post-CAR T-cell therapy. So again, we have a real-world analysis following polatuzumab monotherapy following CAR T-cell therapy. So we don't typically use it a lot post-CAR T-cell therapy. And so why is it just included in my brief mentions? It's because we don't really utilize it a lot post-CAR T-cell therapy, and that's the reason it's important. The first is there is a new frontline treatment regimen that's just been around for about the past 4 years, something called Pola-R-CHP, which incorporates polatuzumab into the very frontline chemotherapy regimen for patients in a subset of patients. And so a lot of patients now who are relapsing post-CAR T have already seen polatuzumab and have progressed on it. So we wouldn't typically reach for a polatuzumab-based therapy in those patients. It's also frequently utilized as a bridging therapy for CAR T-cell therapy. So while patients are waiting for their cells to be manufactured in the lab, those 4 to 5 weeks, sometimes polatuzumab is given as a bridging therapy or a temporizing therapy to hold patients' disease at bay while they await their cell processing. And so for patients who don't respond to that bridging therapy, most likely polatuzumab would not be utilized in the post-CAR T-cell setting. So by the time patients are experiencing disease relapse post-CAR T, a good portion of patients have already seen polatuzumab. That being said, again, a multi-center retrospective study examined the use of polatuzumab in the real-world setting post-CAR T-cell therapy and demonstrated an overall response rate of about 44% and a complete response rate of 14%. So polatuzumab does remain a viable treatment in patients without polar refractory disease. And then selinexor is an oral therapy which targets a protein within cancer cells called XPO1, which usually works to inhibit tumor suppressor genes, thereby increasing the activity of innate and tumor suppressor genes. So this treatment's given actually only orally 2 times weekly in patients with relapsed refractory diffuse large B-cell lymphoma, it demonstrated an overall response rate of 28% and a complete response rate of 12%. 3 patients treated with selinexor in the study went on to receive CAR T-cell therapy, but none had previously been treated with CAR T-cell therapy. Okay, so the use of allogeneic stem cell transplant, what it is, the side effects could be an entire 2 talks. So I can't really spend the time truthfully going too much into what an allogeneic stem cell transplant is, but essentially we give a high dose of chemotherapy and then we rescue a patient's bone marrow biopsy with a donor immune system. But the real purpose of the transplant is not the stem cell rescue, so not giving you new blood cells from a donor. The real purpose of the treatment is that in doing so, we actually give a patient someone else's immune system that hasn't gotten used to having cancer cells around. And so their immune system, once it enters a patient's body, is able to recognize residual cancer cells and attack them. And so this has become an effective treatment for diseases like leukemia, and we still do utilize it occasionally in lymphoma. Multi-center retrospective analysis of 88 patients who underwent allotransplant in the post-CAR T-cell setting demonstrated an overall response rate of 76% and a complete response rate of 51%. So again, really want to encourage you not to do cross-trial comparisons, but I will say that these are the highest numbers we've seen in this talk post-CAR T-cell. So why is not everyone getting this treatment? Well, really, allogeneic transplant is most effective when patients are getting allogeneic transplant when they're in a complete response or near complete response. And also, it is not a benign therapy. It needs to be given in a large academic center. It has a lot of long-term toxicities. It needs to be given by a specialist who's undergone special training for this treatment. And so allogeneic transplant, and it can only be given in patients who are quite fit and young. And so allogeneic transplant is not a treatment that can be considered for everybody, but in particularly fit patients who are able to achieve a CR or near CR with some of the therapies we've discussed in today's talk, I do consider allogeneic transplant. And that is, I think, a theme that is going through a lot of the major academic institutions because we really want to give these patients who have a complete response a chance of cure. Okay. Lastly, all of the information and novel therapies discussed here were based on the results of clinical trials. So clinical trials are essential to consider if available for patients relapsing after CAR T. Clinical trials offer the chance to get novel therapies and really also advance the field of science. And they're often sponsored by organizations like the NIH, the NCI, but can be sponsored by things like pharmaceutical companies or even individual medical institutions. And these should not sway you from enrolling in clinical trials. I just want to go over some misconceptions about clinical trials. Clinical trials are not only for people who have no options left. We are constantly enrolling patients in clinical trials immediately post-CAR T-cell relapse. And as you've seen, clearly there are lots of options for patients post-CAR T-cell relapse. In cancer, we do not do clinical trials randomized against a placebo. Clinical trials are either not randomized, so you just get the treatment, or they're randomized against standard of care, which would typically be one of these treatment options I outlined here in this talk. Clinical trials should not cost you anything more than what your insurance already covers. So when you are considering a clinical trial, you'll be assigned a coordinator as well as a physician that will go through a consent form that talks about what costs will be billed to your insurance and what costs are billed to the clinical trial itself. That's why clinical trials have such a large budget to cover costs so that patients should not incur any additional costs than they would if they were proceeding with regular standard of care. And then the last misconception is that you have to completely leave your doctor and move to a new treatment facility. Occasionally, you do have to leave your facility temporarily to get this clinical trial treatment, but I think it is really a goal of large academic institutions to continue to have your local oncologist follow you once you've gotten the study treatment. And so that's something I would really encourage you if that's your only hesitation in proceeding with a clinical trial and discussing with your local oncologist as well as the oncologist talking to you about enrolling in a clinical trial. So in summary, diffuse large B-cell is a treatable cancer with multiple effective lines of therapy for patients experiencing disease relapse after CAR T-cell therapy. We talked about cure rates or complete response rates ranging anywhere from 7% with some treatments all the way up to 51% with allogeneic stem cell transplant and ranging around 35 to 40% with most of the treatments discussed here. That's really amazing in patients who are receiving these treatments as third or greater lines of therapy. Selection of treatment is truly dependent on a variety of patient and disease-specific variables. So it's important to discuss your goals and preferences with your oncologist to choose a treatment that's right for you. If your goal is really not to ever be admitted to the hospital again, perhaps a bispecific antibody is not right for you. But if your goal is, to get the most commonly recommended therapy post-CAR T-cell therapy that has been shown to have the longest duration of response post-CAR T-cell therapy and has been most studied in that setting, then a bispecific is right for you. So it really depends on what your goal is here. Allogeneic stem cell transplant, in my opinion, should be considered in fit patients able to achieve a complete response after CAR T-cell failure. And clinical trials should be considered in patients experiencing disease relapse in the post-CAR T-cell setting in tandem with all of these therapies we've outlined here. So I just want to thank all of you for your time, for listening to me ramble on for almost nearly an hour. And I'd like to open it up to some questions.
Thank you for that wonderful presentation, Dr. Melody. So like Dr. Melody said, it's now time for the discussion part of today's webinar. So if you have any questions about today's topic, feel free to drop them in the chat.
I think I see a hand up from Lila Shepley. So Lila, I'm just going to encourage you to write your question in the chat because I think we had questions come throughout the talk. So we want to make sure we're getting to them in a fair and equitable manner.
Thanks. So the first question is, are there any specific characteristics that make people more likely to fail CAR T?
Yes, there are. It really just depends. So both in CAR T cell therapy and then for these subsequent lines of therapy, there are a great deal of studies evaluating what would most likely cause patients to experience CAR T cell failure. So it depends on the therapy we're talking about post CAR T, but I think the question is pertaining to CAR T specifically. So studies have shown that patients with a genetic mutation called c-MYC mutation in combination with a mutation in the BCL2 gene, you don't need to know that, but we call that a double, or sometimes if it's even in concurrence with an additional mutation in the BCL6 gene, we call it a triple hit lymphoma. These are particularly aggressive types of lymphoma, and they have been shown to be less likely to respond to CAR T cell therapy. Other things that we've known are just cause people to are less likely to respond to CAR T cell therapy are evidence of high disease burden. So that's really hard to describe, but ways that we've tried to characterize disease burden are with a serum blood level called lactate dehydrogenase or LDH. Patients who have markedly LDH prior to CAR T cell therapy are less likely to respond. Patients with significantly bulky disease, so greater than 5 or 10 centimeters, depending on the study you look at. And then patients with CNS involvement are less likely to develop a complete response to CAR T. There are also a significant other number of variables that people consider, but these are the main ones. Advanced age can sometimes be considered as a poor risk factor for proceeding with CAR T cell therapy. And then we calculate a prognosis score, something called an IPI, and patients with a particularly high IPI can also have poor outcomes with CAR T cell therapy. And then again, with each subsequent line of therapy, there are a variety of variables that have been studied. And for the most part, I'm going to just give a general blanket statement. There are nuances to each study, but for the most part, those same factors I outlined that are poor risk factors for CAR T cell therapy hold true for the subsequent lines of therapy. Typically, those factors do convey a more aggressive disease. That does not mean that all hope should be lost. These therapies have been demonstrated to be effective. They're just less effective.
Thank you for that answer. And then the next question is CAR T available, or is CAR T only available in the second line, or can it be used in third line and beyond as well?
Yeah, that's a really great question. Wow, we have some really intellectual patients on this conference. So, CAR T cell therapy, when it was approved in third line and beyond. So, typically, the paradigm for treatment of lymphoma was frontline chemoimmunotherapy. If you experienced disease relapse, you were given salvage chemotherapy followed by an autologous stem cell transplant, which is essentially a lot of chemotherapy and a rescue with your own stem cells. And then if you relapse after that, that's how CAR T cell therapy was approved. But then some landmark studies, the ZUMA-7 clinical trial and the Transform clinical trial were demonstrated superiority over auto transplant with CAR T cell therapy for patients with primary refractory, meaning patients who relapse within 12 months of CAR T cell therapy, early relapse within 12 months of CAR T cell therapy, or primary refractory, meaning patients who did not respond at all to frontline chemotherapy. CAR T cell therapy is approved in the second line setting. So actually, for most patients, CAR T cell therapy is still utilized in the third line setting, but for patients with early relapse or refractory disease, we utilize CAR T in the second line setting. And then there are a lot of studies already evaluating CAR T cell for those patients, which I mentioned, that have a more higher risk disease. So high disease burden, high IPI score, triple hit lymphoma, where we're looking at CAR T cell therapy in the first line setting. And I really do think that for those high risk patients, that's probably where the field is going to head.
Thank you. And then the next question is, what's the oldest age a patient can be to receive CAR T therapy and these subsequent therapies?
Wow. Well, I am not an ageist. So I have seen some very old 40-year-olds and some very young 90-year-olds. So I do not let a number indicate whether or not someone can proceed with CAR T cell therapy. I have been a part of a treatment team that has administered CAR T cell therapy to someone in their 90s effectively. So truthfully, again, I want to just encourage you to engage in a discussion with your physician. There are a lot of components that go into treating someone with CAR T cell therapy. The things I look for are heart and organ function. So I don't really want to give CAR T cell therapy to someone who's really sick from something else that's not their cancer. We also really look at social support. Patients who undergo CAR T-cell therapy, it's a pretty extensive therapy that requires a 14-day hospitalization in most cases. Some places you can get it outpatient, but then they require very frequent hospital visits and a caretaker for up to 30 days post-CAR T-cell therapy 24/7. And they do, so those sorts of things are things that we kind of impact whether or not someone can go for CAR T-cell therapy. But there's a lot of other components that play into whether or not someone can proceed with CAR T-cell therapy. So a very healthy 90-year-old person with no other organ dysfunction is not too old for CAR T-cell therapy, but a 40-year-old who has heart failure and no means of transport and no social infrastructure, I'm probably reaching for that bispecific antibody in combination with chemotherapy in order to give them their most likely chance of cure. And that's not because we don't want to give patients CAR T-cell therapy who don't have that social infrastructure, but it's because studies have shown that it's not safe. And that's really our utmost goal, is to make sure patients are safe and are most likely to get a response to these therapies.
That's amazing that you successfully administered CAR T to a 90-year-old. So thank you for that answer. And I think our last question that we'll have time for today is, are any of these treatments approved for use before CAR T, or do you have to fail CAR T to be able to try them?
So it depends on the therapies we talked about. So some of those therapies that I mentioned, actually most of them, if you remember before they did the real world analysis, where they looked at these therapies post CAR T cell therapy, they were studied in just relapse refractory lymphoma after X amount of lines of therapy, normally 2 or more. And so most of these therapies are available for patients after 2 or more lines of therapy. So to answer the question, you can always receive these there. I'm pretty sure actually all of them. I'm trying to remember everything in the PowerPoint, but I'm pretty confident it's nearly all of them without ever receiving CAR T-cell therapy. None of them mandate CAR T-cell therapy first. However, CAR T-cell therapy, if you remember all of the response rates and complete response rates, CAR T-cell therapy is significantly more effective in achieving a complete response rate at this day and age right now in the time period we're at. You know, 2 years from now, we may watch this presentation again, and that's maybe outdated information. But CAR T cell therapy at this time is the most likely thing to give a patient a cure after with primary refractory or early relapse diffuse large B-cell lymphoma. So if you are near a center that can give CAR T or are deemed CAR T eligible, I do encourage my patients to pursue that treatment. But these treatments are effective in relapse refractory diffuse large B-cell lymphoma without a first experience of CAR T-cell therapy. As a matter of fact, they're sometimes, as you saw in the data today, a little bit less effective, typically if they're administered post-CAR T-cell therapy.
Perfect. Well, thank you so much for those answers, and thank you again for that wonderful presentation. Before we go, I just wanted to quickly highlight some upcoming events that we have. So next Tuesday, we have an event about financial support for blood cancer caregivers and veterans. On Thursday, May 8th, we have a webinar about treatment sequencing for large B-cell lymphoma. And on May 20th, we have a webinar about how exercise can impact your recovery as a lymphoma patient. So we have a lot of exciting virtual and in-person events in the works, so stay tuned. The link to sign up for any of these events and many others will be sent out in the follow-up email. And before we wrap up, I just want to say thank you, a huge thank you again to Dr. Melody for that amazing presentation. And thank you to you all for being part of our lymphoma community. Your support means so much, and we're grateful to have you here. I've included my email on this slide, so please don't hesitate to reach out if you have any questions about HealthTree or any of our programs. And I look forward to seeing you at another webinar soon.